I guess we can get started. This week's Medical Grand Rounds is sponsored by our division, Endocrinology, Metabolism, and Diabetes. And Dr. Roman is away today, so I get the chance to just say hello to everyone. And like he does, sort of mentions things that are noteworthy. I guess the most noteworthy thing this week is the 50th anniversary of Lyndon Johnson's speech to the Congress, in which he began the war on poverty. And you'll remember that this was a very critical time in the country because Kennedy had recently been assassinated. And Johnson had the charge of sort of galvanizing the electorate to say he could do a good job, and also galvanizing all the Kennedy administration people who didn't like Johnson very much. And one of the most noteworthy things Johnson did was begin the war on poverty. And anyone who works in the ACB or works in the ULH knows that that war is still happening. In addition, the FDA has approved a series of drugs in the past week, and I'll just try to read them for you. One is umicitinib, Villafuerte, which is an inhalation. It's called Panerol Ellipta, and it's used for people with COPD. In addition, there is a drug called sulfospurir, or Sulfaldi, which is a tablet which is used for the treatment of chronic hepatitis. Pasaconazole, or Noxafil, is a drug released for the prophylaxis of invasive aspergillosis and Candida albicans. Dapagliflozin, or Farxiga, is a new glucose cotransporter 2 inhibitor that promotes renal glucose excretion and is a new way to treat patients with diabetes. And finally, collagenase Clostridium histolyticum, or Xiaflex, was approved for the treatment of men with Peyronie's disease, a bothersome curvature of the penis. And with that, I'll introduce Dr. Villafuerte, who is an associate professor in the Division of Endocrinology and Metabolism. Betty joined our division in 2003, and she serves as our section chief at Jewish Hospital, where our major focus is in diabetes. Dr. Villafuerte is a specialist in type 2 diabetes, and she has a great deal of insight and research experience on the study of insulin signaling and insulin receptors and the various genes which are involved in insulin signaling. She's expanded this interest to include the connection between insulin resistance and cancer. So about 10 years ago, Dr. Villafuerte identified and cloned a gene for insulin response DNA binding protein 1, which he called sensitin. And this is a protein which he found regulates insulin responsive genes and improves insulin sensitivity. So one of the key target cells in the body for insulin is the adipocyte. And today, Dr. Villafuerte is going to talk to us about adipose disorders masquerading as obesity. Thanks so much.
That's the end of the talk. Okay. I'm going to talk about a bunch of unrecognized diseases. Primarily, it's a lipid disorder, adipose tissue disorders that are largely unrecognized by us, or commonly misdiagnosed also. There are two subtypes of adipose tissue. Can you hear me? Okay. The white adipose tissues main function is to store excess energy in the form of triacylglycerol. The brown adipose tissue are rich in mitochondria and are characterized by the presence of uncoupling protein 1 enzyme, which dissipates energy in the form of heat. There's a lot of interest in expanding brown adipose tissue so that we can eat without accumulating any fat. Okay? And On a PET scan, it has been shown that the brown adipose tissue are located in the cervical area, supraclavicular, mediastinal, interscapular, perirenal, omental, mesenteric, pericardial, intercostal, and axillary area. Now, we are familiar with white adipose tissue accumulation from obesity that leads to a lot of human chronic diseases, including diabetes, cardiovascular disease, dyslipidemia, and obstructive sleep apnea, hypogonadism. On the other hand, most of us are not familiar with adipose tissue diseases. And adipose tissue diseases can manifest as abnormality in quantity, quality, and distribution. In general, we think of adipose tissue as storing fat, secreting adipokines, controlling energy metabolism, and our adaptive inflammatory response, and it promotes aromatization of androgen into estrogen. Now, lipoma is a benign tumor composed mostly of white adipose tissue, and histologically you'll see uniform nuclei. So it's considered mostly as benign tumor, but 1 to 4% can recur. It is the most common mesenchymal and soft tissue tumor, consists of 16% of mesenchymal neoplasm. It occurs mostly in people over 40 years old. There's no gender or ethnic preference, and usually it's located in the trunk, back, shoulder, neck, proximal extremities. And usually it's located in the subcutaneous area, and it can occur also in unusual sites, such as oral cavity, pancreas, the breast, intestines. It will go through a growth phase, and then the growth becomes static. It does not regress with starvation, and it becomes hard after you apply ice on top of it. Most of the lipoma are located in the subcutaneous tissue, but it can occur also below the fascia, so it's a subfacial lipoma. It can also occur in the muscle, so it could be intramuscular. In the respiratory tract and the GI tract, it can occur in the submucosal area or in the subserosal area. If it occurs in the subcutaneous area, it is generally mobile, lobular, and it slips under the palpating fingers, so you can be sure that it's easy to diagnose. The differential diagnosis is neurofibroma. This is the most common variety of lipoma. If it's located below the fascia, you cannot palpate the edge, or you cannot be sure that there's a lobulated mass in it. You have to differentiate it with dermoid and tuberculosis tenosynovitis. And if it occurs in the scalp area, it could erode the bone. If it's in the subsynovial or intra-articular area, you'll note knee or elbow swelling. It has to be differentiated from bursa or Baker's cyst, and this is rare in general. If it's in the muscle, you have to differentiate it from fibrosarcoma or hematoma. If it's bony or parosteal, it will feel hard. You have to differentiate it from primary bony tumor. If it's in the submucosal area and it occurs in the laryngeal area, you'll have stridor, and if it's in the intestinal area, it's a cause for intussusception. If it's in the subserosal area, it's usually located in the retroperitoneum, and then you have to look at it more seriously because it can cause hydronephrosis, and it has to be differentiated from liposarcoma. If it's in the gland, it usually occurs in the breast or pancreas, and these are rare. So generally, most of the lipoma are localized, lobular, non-tender. It's mobile. It slips under your finger. It's skin-free, and it can be pedunculated or not. The complications of lipoma in general are it can degenerate into myxoma, so it becomes fibrous and hard. It can saponify, so it will produce soap-like substance. It can get calcified, infected, ulceration. It can get ulcerated. It can cause intussusception and intestinal obstruction. It has to be differentiated from liposarcoma. And liposarcoma is generally located in the retroperitoneum, the thigh, or the back. And it's rapidly growing tumor that's warm and vascular. You can see dilated veins over the surface of the tumor. Like any cancer, it's restricted in mobility because it's fixed to the surrounding tissue, and it can spread hematogenously. Now, this is not a talk about surgery, okay? The slip sign means you can put your finger between the tumor and the lower part of the lipoma. Most of the lipomas, about 95%, are just one tumor, but about 5% will have multiple lipomas. And as I mentioned before, it could occur intraglandularly in the breast area. We're going to talk today about the multiple lipomas. Now, this is an illustration of actual cases that I have seen for the past few years. This is a 36-year-old Caucasian female who had a 2-year history of pain in the legs, hips, abdomen, and breast. She herself detected subcutaneous fatty lumps inside her thigh. And 8 months ago, her symptoms got worse with extreme fatigue, so that she could not stand or walk, and she quit her job as a special ed educator. She has insomnia because of the excruciating pain, and the painful lumps, according to her, are getting bigger. She coughs a lot with brown and pink phlegm and tested negative for tuberculosis. She has difficulty losing weight, although she tried to eat a 1,000 to 12,000 kilocalorie diet daily and swim an hour every day. She saw 3 rheumatologists in town and more than 10 physicians in the Louisville area. She was not diagnosed until she went to UC San Diego and saw Dr. Karen Herbs, who's a specialist in rare adipose tissue disorders, and she was diagnosed with Dercum's disease. I think the next case is more a common scenario that we see clinically. This is a 43-year-old Caucasian female whom I first saw in December of 2009. She complained of weight gain, fatigue, worsening migraine headache, chronic pain, complaining of stiff hands, knees, and even a light blanket can cause pain in her legs. She also complained of generalized weakness, weight gain despite 2 hours of aerobic exercise daily, she's a physical therapist, so she can do all the exercise, I guess. She has dyspnea, intermittent diarrhea alternating with constipation, itching, swelling, forgetfulness, confusion, depression, and insomnia. When you see this type of patient, you will think of chronic fatigue or fibromyalgia. However, she gave me a history that 5 years ago, she saw another endocrinologist in town and was diagnosed as having hypopituitarism. She was diagnosed by an insulin tolerance test, so she was given IV insulin to induce hypoglycemia, and then her growth hormone was measured and her cortisol was measured at that time, and the growth hormone was actually normal. The cortisol was lower than expected for somebody who has a glucose of 33 milligram per deciliter. And her MRI at that time showed no pituitary adenoma, normal posterior bright spot, so there's no diabetes insipidus. Infundibulum was midline. Her optic chiasm nerve and optic tracts were both intact. However, the endocrinologist started her on Synthroid, growth hormone therapy, and prednisone, and pretty high dose of prednisone, 5 milligram in the morning, 2.5 milligram at 10:30 in the morning, and another 2.5 milligram at 2 p.m. Then a few months later, she developed PE and DVT and was put on warfarin. Her only past surgical history is she has 2 lipomas removed from the left arm. And she has a hospitalization for idiopathic anaphylaxis while exercising. So there is nothing here that I really thought the patient has chronic fatigue syndrome, fibromyalgia. So I keep on seeing the patient. All I told her is, based on her insulin tolerance test, I could withdraw her from prednisone treatment and growth hormone treatment. So eventually we were able to withdraw her after a year from prednisone treatment. Now, 4 years later, she's still my patient, still complaining of fatigue with whole body pain, and she can barely hold her head up. She kept on asking me, why can't you make me feel better? And her question is, just because I have chronic fatigue, that it does not mean that I have lost ambition in my life. I still want to go back to work as a physical therapist. Now she's complaining of being swollen, worse when she fly by airplane, and she felt like being squeezed. She felt like something is under her skin, then it will eventually develop into lipoma. And the lipomas actually hurt, but not all of them. This time I did a physical examination, something that we don't normally do when we see obese patients, primarily because we just assume that all of these are from their obesity. So this time the physical examination showed she had a predominantly abdominal obesity. There's nodular matted fat all along her arm, tender nodular fat in the cubital area. She has panniculus of the upper abdomen, nodular thick fat on the thigh with bubble pattern in the thigh area, which looks like any obese patient. There's medial nodular fat pads in the knees. There's no pitting edema, and the stemmer sign was negative. So my diagnosis, after seeing the patient for 4 years and not doing much about anything, is Zircon's disease with vascular component, probably mast cell activation, and stage 2, lipoedema. So stammer signs is when you try to pinch the skin at the base of the second toe. It's negative if you can pinch the skin there, and it's positive means it's the foot is all swollen and you cannot pinch the skin in that area anymore. That's more characteristic of lymphedema rather than lipoedema. So what is Dercum's disease? Dercum's disease is otherwise known as adiposa dolorosa, morbus Dercum, adisopalgia, lipomatosis dolorosa, adipose tissue rheumatism. It was first described by Francis Xavier Dercum in 1888 from the University of Pennsylvania when he presented the first 3 cases of Dercum's disease. It was recognized as a clinical entity in 1892. It is an accumulation of chronically painful subcutaneous fatty deposits, often in the form of nodules or lipomas, and the size of nodules could be from a rice granular size to a whole fist size. It is accompanied by generalized overweight or obesity, but the pathognomonic sign is there's pronounced pain in the adipose tissue. The pain is chronic, symmetrical, disabling, resistant to analgesic. Most common locations are in the extremities, the trunks, the pelvic area, and the buttocks. The painful lipomas vary in size and firmness. It usually occurs in women between age 35 to 50 years old. 86% of them occurs before menopause. The average onset is 35 years old. It's 5 to 7 times more common in women. And in Sweden, there's a population study showing that the incidence is about 1 per 1,000 women. These are the typical distribution of Dercum's disease. It is in the inner arm, upper arm. In the thigh area, it's in the outer and the inner thigh area. In the abdomen, the buttocks in particular. In a survey of 110 patients with Dercum's disease, Herbst and Asari showed that the location of the growth of lipomas is actually quite diffuse. Anywhere in the body it can occur. In the scalp area, 32%, neck area, posterior trunk area, the buttocks in particular, anterior trunk, arms, wrists, hands, legs, ankles. The legs is very common, especially the knee area and the feet. Pain is pathognomonic for this disease. About 99% of the patients has pain. And the growth of the lipomas, as expected, is unaffected by weight loss. It's accompanied by easy bruisability, lots of sight problems, including sleep disturbance, impaired memory, depression, difficulty concentrating, anxiety. They complain of rapid heart rate. Both of these patients I have put on beta blocker because of these same complaints. They complained of shortness of breath, even though their oxygen saturation is consistently normal. Only about 70% of these people are obese, and 16% have diabetes. They have lots of GI complaints, including bloating, constipation, rheumatological symptoms, including fatigue, weakness, joint aches, and muscle aches. These are very generic symptoms that we tend to attribute to fibromyalgia or chronic fatigue syndrome. The cardinal signs is there should be palpable fat deposit, and there should be pain in the fat in the area where the fats are located for at least 3 months. asthenia or weakness or fatigue is very common. It usually gets worse with exercise or increased activity. It also is aggravated by changes in temperature, etc. They have cognitive change. They usually complain of brain fog. They have weight gain, difficulty losing weight. Even gastric bypass surgery does not correct the obesity. They have vascular involvement, so you usually see some cherry angioma, some petechiae on top of those lipomas. You can see some hematomas because of their easy bruisability. So it is characterized by edema of the subcutaneous adipose tissue. And again, they have all the other ancillary symptoms that you can attribute to chronic fatigue syndrome. It is classified into generalized diffuse form, generalized nodular form, localized nodular form, or it can be near the joint, so it's juxta-articular. Again, the pathognomonic sign is chronically painful adipose tissue that lasts for more than 3 months. Sometimes it is very hard to distinguish from general obesity. For example, this lady has a type 1 Dercum's disease. Therefore, all these markings are where the lipomas are located. If you see this type of patients, it's really hard to distinguish it from generalized obesity unless you do a very careful physical exam. You have to feel the fat folds. It felt like Beanie Baby, or the beans in a bag, okay? And especially it's more pronounced in the knee and the hip area. So as you can see, it's hardly distinguishable from generalized obesity. Now, it's easier to make the diagnosis of nodular form of Dercum's disease. I have one patient who has been taking this type of pictures for 7 years and keep on showing it to me. What are these, Doc? I said, I don't know. Finally, after 7 years, I told her, I know what's wrong with you. So it could look like grape-like clustered lipomas, and they're very tender when you palpate it. As I said, it could be juxta-articular. For example, this lady has a lipoma in the hip area, which you really can easily miss. This side does not have the lipoma, but this one is the one that is causing the hip pain in this person. When you do a biopsy of this lesion, it's actually just a mature adipose tissue without significant vascular or neural proliferation or inflammation. The adipocytes are larger than normal compared to normal obesity. And in about 30% of the cases, there's some blood vessel growth, and it's considered to be angiolipomas. And there's some muscle and granuloma formation around the blood vessels, suggesting foreign body infiltration. On MRI, their subcutaneous adipose tissue are actually much thicker compared to normal people, normal obese people, but you don't actually see the lobules or like each individual lipomas. What you see is the faint blast-like signal that occurs. This appears to be the pathognomonic sign of this disease on MRI. So probably this suggests that most of it are angiolipomas. The differential diagnoses are, of course, fibromyalgia, Lipoedema. Lipoedema is when the when the fat deposition occur predominantly on the lower extremities. Panniculitis are inflammatory conditions in the subcutaneous area, including the connective tissue, septa, and fat lobules. Cushing syndrome because of the abnormal fat accumulation, hypothyroidism because of the fatigue and joint pain, and psychiatric conditions such as depression. Pain is very common in depression. The physiology mainly involve vascular and lymphatic dysfunction. In general, lipomas are not painful unless you have concurrent lymphatic dysfunction. Usually there's local lymphedema that produce strangulation of the local lymph and blood vessels. The chest is usually a very common area for lymphatic dysfunction, primarily because it's full of lymphatic vessels, and they usually complain of discomfort when they wear their bra. They usually have vascular dysfunction presenting as hematemesis, epistaxis, hematochezia, heavy menstrual period. They have prominent varicose vein, altered vasoconstrictor response. They can also present as unusual symptoms such as septic shock from necrosis of the fat, dysarthria because the lipoma involved the brain, hydronephrosis when it's in the retroperitoneum, mastalgia when it's in the tongue. They can present as painful scalp and weight loss failure after Roux-en-Y gastric bypass surgery. The etiology is really unknown. It has been postulated initially that it's endocrine in etiology, primarily because of autopsy findings of the atrophy of most of the endocrine glands, but that usually can occur also with chronic pain. It could be abnormal connections between autonomic and sensory nerves in the periphery, although that was not proven eventually. It could be adipose tissue dysfunction, since the proportion of saturated to unsaturated fats were generally increased. But it could be inflammatory, but most of the adipokines, CRP, and cedrate are comparable to similarly obese subjects. There's some genetic component. It has been reported in some families. Immune dysfunction, probably partial mitochondrial deficiency. And none of this has been proven correct. Most of the cases are sporadic and does not have family history. So what are the recommended treatment? Lymphatic decongestive therapy, like what you would do for lymphedema, except you target it to the area where the lipomas are. So, example, if there's an arm, you get the lymphatic compression stacking in the arm, or if it's in the trunk, you get it in the trunk wrapping. Exercise, aqualymphatic therapy, whole body vibration therapy to improve circulation of the lymphatic drainage, and also altitude simulator, increasing the pressure up to 10,000 feet to 22,000 feet. That it appears to improve the lymphatic circulation. Liposuction, for example, if it's in the hip area, to remove it surgically is indicated. Other recommendations include beta-adrenergic agonists, which can induce up to, this is very high dose of beta-adrenergic agonists, can induce up to 20 kilogram weight loss. Diuretics are discouraged primarily because it can promote fibrosclerosis and Pseudo-Bartter syndrome, so you end up with hypokalemic, hypochloremic alkalosis, and activation of the renin-angiotensin-aldosterone system, and elevated ANP. Flavonoids like quercetin has been tried in some people. Selenium appears to improve the lymphatic drainage considerably. Shockwave therapy. My patients went for IV lidocaine, which has been reported to improve the pain symptoms from 2 weeks to a year sometime. Some patients receive chemotherapy using methotrexate and infliximab. Interferon alpha 2b, which was being given for hepatitis, appears to improve the symptoms also. Corticosteroids is controversial. Systemic corticosteroid tends to increase growth in the lipomas. But localized injection of corticosteroid may be indicated when it's near the joints. Ranexa has also been tried, which I tried in 2 of my patients, which appears to help a little, not a lot. Now, aside from Dercum's disease, we need to be aware that there are certain syndromes that is associated with multiple lipomas. The more common one, the more familiar to us is the ME1N1 patients, multiple endocrine neoplasia patients, and patients with neurofibromatosis. Now, there's also a group of diseases in which the lipomas are not painful. Okay, this can occur with benign symmetric lipomatosis or Mandelung's disease, the familial lipomatosis syndrome, congenital lipomatosis, and lipedema. So, multiple symmetric lipomatosis are painless fat accumulation, and these are mostly brown adipose tissue. So histologically, when you look at the white adipose tissue, the lipid droplet is just one big blob. On the other hand, in the brown adipose tissue, they have multiple lipid droplets. So you can look at it histologically, and even without staining them for uncoupling protein 1. In the type 1 multiple symmetric lipomatosis, the lipomas occurs in the head and neck area with extension to the back. It can compress laryngeal nerve, tracheal, or it can cause tracheal or esophageal compression, superior vena cava syndrome, and it can develop as buffalo hump. Type 2 involves the shoulder girdle, upper arm, thorax, back, abdomen, and upper buttocks. And the type 3 involves the thigh area. And again, histologically, they're mostly brown adipose tissue. So this is type 1, in which there's accumulation in the neck area. This is associated with mitochondrial DNA deletion mutation, occurs in middle-aged men with a history of alcohol abuse. It's associated with axonal sensory neuropathy in 60% of the cases. So I have seen one case in which the patient is really wheelchair-bound. And it can be differentiated from alcohol-induced neuropathy primarily because alcohol-induced neuropathy is demyelination. Therefore, it's a burning type of pain. In this case, it's just muscle weakness. It can rarely transform into malignancy. It has a high recurrence rate, even if you remove it by surgery. It's associated with diabetes, hyperlipidemia, hyperuricemia, macrocytic anemia, oral cancer, and sleep apnea. The type 2 are the ones that involve the shoulder area and the upper arm area. It can also occur in a very isolated fashion. Therefore, for this lady, it's an upper arm and then the suprascapular area that's involved. This is a typical of type 2, multiple symmetric lipomatosis. It can involve the breast area. This is a male patient. CT scan showed these are adipose tissue. And this same patient has 2 lipomas in his interscapular area. These are 2 10 centimeter lipomas. It can occur in the breast, and at the same time, it can occur in the upper arm, as shown here. The treatment is, of course, alcohol abstinence, lymphatic decongestive therapy. Again, it's the lymphatic drainage is the main problem in these patients. Surgical resection and liposuction, beta-2 adrenergic agonist. Some has reported that fibric acid, growth hormone therapy, local steroid seems to help. Now, sometimes the Mandelung's disease could be very isolated. For example, in this person, it's in the cervical area, periauricular area, the nape area, again in front, periauricular area. And so it can be very localized. Now, the next subject will be on fat accumulation in the legs. This is the most misdiagnosed type of clinical presentation. We know that with leg swelling, it could be systemic in etiology, such as idiopathic cyclic edema, heart failure in cirrhotic patient with renal failure, and hypoproteinemic states. But outside of these systemic causes, it could be fat accumulation in the lower extremities versus lymphedema and venous swelling from phlebiodema or venous insufficiency. Lipoedema is lower extremity enlargement due to subcutaneous deposition of adipose tissue. It is generally unrecognized by medical providers, although it's a very common disease. MRI showed that the subcutaneous adipose tissue and skin is thicker than control, and the muscle mass is not edematous. It has to be differentiated from lymphedema, which is characterized by accumulation of protein-rich interstitial fluid in the skin and subcutaneous tissue caused by lymphatic dysfunction. In general, with lymphedema, the foot and the toes are affected, so your Stemmer sign is positive. You cannot pinch the skin in the second toe area. And the swelling is characteristically hard because the skin thickens and you get the orange color because of dermal lymphatics. You can also develop cracks in the skin, leaking lymphatic fluid out as lymphoria. On MRI, you see honeycomb pattern between the muscles and subcutaneous area. Phlebiodema is chronic venous incompetence, and when you look at it on the MRI, you see increased amount of intramuscular fluid and subcutaneous fat. So lipoedema, as I said, fat accumulation in the legs is very common. It's extensive deposition of subcutaneous adipose tissue from the iliac crest to the malleoli. 30% will involve the upper arm. The fat are tender, so it's like Dercum's disease. It felt like round peas in a plastic bag. A radiologic study of oral swollen legs showed that it affects 11% of the female population, mostly women in their 3rd decade of life. 60% of this is inherited as autosomal dominant trait with incomplete penetrance. It's usually bilateral, symmetric, with minimal involvement of the feet. It's a non-pitting edema, and it's persistent despite elevation of the extremities or weight loss, and it is associated with easy bruisability. So how does it look? On stage 1, you can hardly distinguish it from any obese legs, except the patient complain of pain in their legs. On stage 2, the skin are now involved, so you have mattress-like skin formation. What you have to remember is lipedema can involve the buttocks area. Lymphedema does not involve the buttocks area. So you can end up with a saddlebag appearance of the buttock area. Again, you can have pantaloon-like distribution of the fat. Look, it looks like the patient has is wearing a pants primarily because the feet are spared. So this is what you see. The feet are generally spared. By contrast, in venous insufficiency, you see the chronic venous insufficiency, the increased pigmentation that is associated with chronic venous insufficiency. Whereas in lymphedema, you end up with foot involvement so that you have a positive stemmer sign. Again, it could be very subtle. This looks like, unless you disrobe the patient and look at it as a whole, you really cannot identify the problem. This looks just like any swollen leg. This has more lipomatosis distribution. It could involve the buttocks predominantly. Again, with lymphedema, you do not see buttocks involvement, and it has a JAG4 distribution, so it's like the pants that they used in the 20s. It have a Michelin tire appearance sometimes. And now, if you do not treat it correctly, eventually, with the lymphatic involvement, you'll end up with lympholipedema. So, because you did not treat it correctly, when it presented as a lipedema, it will end up to have secondary lymphatic obstructive symptoms, and you'll end up with the skin changes that occur with, you'll end up with skin changes that usually associated with lymphedema. So with drainage of the lymphatic fluid. It can, in 30% of the cases, involve the upper extremities. On MRI, you'll see a lot of the subcutaneous fat, which are generally sepsated, and there's no edema of the muscles. Again, because it's more common clinically compared to other fat accumulation diseases, I'm going to compare this with lymphedema. Lipedema occurs exclusively in women, whereas lymphedema is equally common in men and women. At age of onset is puberty with lipedema. So most patients will start complaining of leg pain starting from their teenage year, whereas lymphedema can occur at any age. Lymphedema could be primary or secondary. Primary is when they have structural developmental defect that could be bilateral, but most of it are secondary because of lymph node dissection or malignancy or infection. So you'll end up with mostly unilateral swelling, or one leg is affected more severely than the other with lymphedema. Whereas in lipedema, it's usually symmetric. Both legs are swollen. In terms of epidermal changes, you don't get the hard, cracky skin that you get with lymphedema. The skin are soft with lipedema. In terms of foot involvement, you see that with lymphedema, but not with lipedema. Buttocks involvement occurs with lipedema, but not lymphedema. Although they're both swollen, it's soft and non-pitting in lipedema, whereas it is usually firm and often markedly pitting with lymphedema. The tenderness is common with lipedema, so it's more painful with lipedema compared to lymphedema. Easy bruising is occurs in lipedema. Improvement of symptoms with elevation and compression stacking occurs with lymphedema, but not lipedema. There's more family history. Family history is more frequent with lipedema. History of cellulitis, lymphangitis, or venous diseases is more common with lymphedema. And lymphedema increase your risk for angiosarcoma. In terms of MRI findings, all you see with lipedema is increased subcutaneous fat with little fibrosis, and there's no thickening of the skin. Whereas in lymphedema, you see honeycomb pattern fibrosis, edematous fluid in the fat and in the muscles, and skin thickening. The treatment is also lymphatic decongestive therapy. You want to prevent the lymphatic obstruction that can occur with prolonged, with all this fat growth causing lymphatic obstruction. The difference is liposuction is very effective for this type of problem. But first, you need to do lymphoscintigraphy to make sure that there's no major lymphatic damage before you do liposuction. Otherwise, they'll end up with seroma and hematoma formation. Steroid treatment has been used to decrease pain. Diuretics is contraindicated because it can cause fibrosclerosis. So essentially, you're just making them more fibrous and hard. Selenium therapy appears to help, and shockwave therapy. Lastly, I'm going to talk about familial multiple lipomatosis. This runs in the family and it could be several hundreds of lipomas or thousands of lipomas. These are multiple discrete encapsulated lipomas in the trunks and extremities. It's more common in men than women. Okay, it comes as a generalized lipomatosis that involves the groin, trochanter, and hip and thigh area. This is actually quite common. I've seen in at least 5 or 6 of my patients with this problem. Okay, and it could be just in the trochanter area. It could be peritrochanteric. Usually occurs in patients of Mediterranean or North African origin, and it involves a translocation of the high mobility group gene. Lastly, sorry, I thought I'd finished. We will talk about lipodystrophy. So in addition to all this lipoma, lack of subcutaneous adipose tissue is also associated with metabolic syndrome. This is a case of a 17-year-old whom I saw because she cannot stretch her Achilles tendon. And her mother noted that she was walking on tiptoe, and she has increasing body fat at the same time. She also has developed the frog's neck appearance with widening of the neck with skin fold. And you can easily mistake this patient as having double chin from obesity. But actually, this patient has Donegan type of familial partial lipodystrophy. This is actually quite common in the diabetic population. The key is you need to look at their legs. When they're presented with double chin, do not assume that they are only obese. What you have to look at is their legs. If they have a very muscular legs with prominent muscle and you can see their superficial vein, chances are they have lost their subcutaneous fat in the leg and in the extremities. And this is characteristics of the Donegan syndrome. Again, they mostly presented as having double chin. And this is part of a laminopathy, meaning mutation in the lamin A and lamin C gene. So it's a nuclear protein problem. Again, the characteristic is they have frog's neck appearance, and pseudohypertrophy of the thugs is nearly always a pathognomonic sign, and their BMI is usually less than 25. And on physical exam, you can see that their biacromial diameter is greater than their bitrochanteric diameter. They have small breasts. They have fat accumulation in their bulbar area. And they have glucose intolerance, high triglyceride with low HDL, hepatic steatosis, elevated CPK, increased testosterone, and PCOS. The treatment for this is thiazolidinedione and leptin. More familiar to most of us are acquired lipodystrophy. Glucocorticoid use, especially high-dose glucocorticoid use, can lead to fat accumulation in any parts of the body, including some patients who look like they have Mandelung's disease. Injection of insulin can also lead to lipoatrophy, primarily because, I guess I have to go faster. Okay. Primarily because you induce local insulin resistance in the area where the patients are injecting insulin consistently. And because of the insulin resistance in the area where they're injecting insulin, they can lead to increased lipolysis and atrophy of the fat. Barker-Simons syndrome is when the fat accumulation occurs from the hip down and you lose fat in the upper area of the body. This usually occurs after a viral syndrome, and it's associated with complement pathway C3 nephritic factor activation, and it's frequently associated with membranoproliferative glomerulonephritis. And you can see that in Barker syndrome, you lose the fat in the upper area of the body and you accumulate the fat in this area. Finally, HIV lipodystrophy occurs in about 50% of HIV infected patients. It is characterized by peripheral lipoatrophy, central hypertrophy, metabolic disorders such as dyslipidemia, and impaired glucose tolerances. Each of the antiretroviral therapy has characteristic effect on the fat, primarily because it can cause alter the transcription factor of adipocytes and also cause apoptosis of the adipocytes. And FDA has approved a growth hormone releasing factor for the treatment of HIV lipodystrophy. And you can see that fat accumulation in the belly, you get a buffalo ham. The most dreaded lipodystrophy for HIV is in the cheek, primarily because they stand out as having HIV infection, even when just looking at them. And you can see that the atrophy of the fat in the buccal area can occur significantly in HIV-infected patients. It can also occur with HIV treatment. It can also occur as multiple symmetric lipomatosis, as shown in this female. And more importantly, in a non-Caucasian female, it usually occurs in the breast area. So most HIV-infected patients will have very large breasts. Again, in summary, rare adipose tissue disorders, including multiple symmetric lipomatosis, lipedema, and Dercum's disease, result in widespread increase in subcutaneous accumulation of subcutaneous adipose tissue. Lifestyle changes and bariatric surgery do not decrease the fat accumulation, and it likely results mostly from accumulation of brown adipose stem cell population with secondary lymphatic dysfunction. So most of the treatment are focused on lymphatic decongestive therapy, and it needs to be distinguished from familial partial lipodystrophy. Acquired partial lipodystrophy even occurs with metabolic syndrome alone, and generalized obesity. This is the end. Any questions?
Thank you very much for sharing these unusual and perplexing diseases with us. It's kind of late. Perhaps one question, if there is a pressing question. Otherwise, ask Betty afterwards. Thanks so much. Fine. Thank you.